We're going to talk about the World Health Organization scheme, the last one in 2016, and some updates since then. And just to let you know, just as a warning, there's actually a new WHO coming out if everything goes on schedule at the end of the year. I'll believe it when I see it, but that's the plan. So we're going to talk about the WHO. What we all do as pathologists, of course, is pattern recognition, and sometimes our clinical colleagues like to tease us about that. But of course, everybody does pattern recognition. You don't have to be a pathologist. So those of you that are old enough to remember, this is Elvis Presley. And within a millisecond, your brain told you that this is Elvis Presley. You didn't have to do any DNA analysis. You didn't have to do any morphometry. So it's really amazing how your brain can take in hundreds or thousands of little clues, morphologic clues, to tell you this. But of course, there's an issue with that, and maybe those of you who have sharp eyes in the front could tell these two are actually not Elvis Presley. Those are Elvis Presley impersonators. And while they may look very similar to Elvis Presley, maybe the behavior is not quite the same. Tumors are like that too, right? Sometimes we see two tumors that look remarkably similar morphologically, and yet the behavior is completely different. Of course, the other thing that we all face on a daily basis is that we sometimes get mixed signals. And we're not quite sure which direction to go based on just purely the morphologic signals. So this is where molecular pathology has been coming in, as I'm sure you know, not just in neuropathology, but in all of pathology for over a decade now. And certainly it's changed the way we've done things in neuropathology. So for example, if you take just a single diagnostic entity such as glioblastoma, this is what was done in 2012 in this study, and do genomic analysis on these tumors, what you find is it's not one specific entity, but at least 6 in terms of molecular characterization. The splitters are winning out these days, but basically some of these have prognostic significance. Some of them occur at different ages, some occur in different locations and have distinctive features. And we're going to talk about several of these, and the 3 that I put here in the green boxes all have surrogate immunostains. So I'm trying to highlight whenever possible what you can do with just purely H&E and immunohistochemistry. So I know you can't read this. This is from the last edition of our practical surgical neuropathology book, the Kevin Leslie series, and looking at pattern-based approaches. And we had a new chapter in there on molecular patterns in the second edition. And so there's about 50 or 60, at least, entities that now have characteristic signatures, genetic signatures to them. So even though you can't read them, this is why we've decided to kind of incorporate some of this into what we're doing diagnostically. So the way this started before the last WHO was in 2014, we had a meeting in Haarlem in the Netherlands, and to decide what are the rules for how we incorporate molecular genetic aspects into the definitions of our diagnostic entities. And one of the things that we published from this meeting was that we wanted to try to define diagnostic entities as narrowly as possible. And so with this in mind, a few weeks ago, you have to understand I was quite delighted to find that someone had decided that I'm the director of neuropathology at UCSF. So they must have been reading the Haarlem paper. I'm sure that's what they had in mind. So in all seriousness, what we published was that we try to approach diagnoses in a layered format, much like what you get when you're looking at a Google map. You get all these different layers of different types of information all stacked on top of each other. And we do the same thing with our diagnoses. So we recommended, of course, like anything else, you start with histologic classification. What does it look like under the microscope? what is the WHO grade, which is based on natural history, and what additional molecular information can we get about that. You put all of those together and you get what's called an integrated diagnosis, incorporating all aspects of tissue diagnosis. And we decided to put that on the top because that, of course, is the most important feature. So this was our group that we met in 2015 to finish out the last-minute controversies, and I particularly like this photo. Looks like we're gazing up into the heavens, looking for divine inspiration, and I don't know if we got it or not. Hopefully we did. And this is the 2016 WHO. So the things we're going to talk about are the ones that changed the most. The diffuse gliomas. A lot of this is based on the status of a gene called IDH1 and IDH2 we'll talk about. Embryonal tumors in pediatrics, we'll talk a little bit about that because they shifted quite a bit, and at least one subtype of ependymoma. So after the WHO was published, we also put together this group called the C-Impact Now for in between the WHOs for classification updates and things like that. And as you can see, this stands for Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. Quite a mouthful. The now is actually not officially WHO, which is it's a little funny because it's mostly the same people that are on both groups. So hopefully we will accept our own recommendations when the time comes.